And I think we are ready to start because it's 5:05. Dear participants, my name is Dr. Julia Zając, and I would like to welcome you at another EuroBloodNet's first day webinar. And dear audience, please welcome with me today's speaker, Professor Valeria Santini, who is leading today a session on when is molecular analysis useful in MDS. Valeria Santini is Associate Professor of Hematology at the University of Florence, Italy. Professor Santini runs the MDS Unit Hematology Department of Experimental and Clinical Medicine at the University of Florence. Her interests are focused on clinical and translational research in MDS and elderly AML. Professor Santini is the president of two national MDS societies, a member of many prestigious national and international committees, including organizations such as European School of Hematology and European Hematology Association. Professor Santini is one of the three key opinion leaders for MDS working group in the European Harmony 2020 research project. She is also an author of more than 200 peer-reviewed papers published in international journals. She's a member of the editorial board of Blood Journal and documented reviewer for high impact factor scientific journals. She has been an invited speaker at numerous international meetings, including American Society of Clinical Oncology, American Society of Hematology, European Hematology Association, and National Hematology Societies of several countries. Professor Santini, the floor is yours.
Thank you very much, Julia, for the very nice introduction. Today's task for me is to discuss when is molecular analysis useful in MDS. But before doing so, I have to show you my conflict of interest. And this has been already said. So the learning objective of today are to understand the frequency and recurrence of somatic mutation in MDS, their prognostic role and the role of the number of somatic mutation, and identify the cases in which molecular study is really necessary in MDS. So these are just is an overview of the technique that can be defined as molecular technique. Of course, some of them are not so frequently used in MDS. The big step forward has been made by the use of next generation sequencing, that the NGS so-called, that allowed the sequencing of a vast amount of data and the production of vast amount of data in a single test, so that we could really have a lot of information at once. But what is the role of molecular analysis in MDS in 2020? First of all, the prognostic importance of somatic mutation is now well established. We have also to evaluate genetic predisposition, and the approach to new therapeutic agents is probably based also on the knowledge and the analysis of molecular alteration in MDS. I will not speak today about the novel insight in pathophysiology that are possible with the study of the methylome and histone modification, and largely with the study of epigenetic modification, because it's a very broad chapter. Now, somatic mutation in MDS are present in the vast majority of cases, more than 80% of cases. These are the two pivotal studies, and these studies have not only shown that the majority of patients with MDS do harbor mutation, but also the frequency and the most frequent mutation that are present, being SF3B1 and TET2. Now, the mutation present in MDS have a stereotype position during the progression of the disease. Some of them appear pretty early in the transforming self, And then some others appear lately are added during the advancement of the disease and progression of the disease. Now, what means evaluating the somatic mutation in MDS? And what is the importance? First of all, they help refining diagnosis. We will see the WHO classification for MDS with a ring sideroblast. Knowing the presence of mutation may prompt an earlier intervention in the presence of multiple of them. There is a very well-known prognostic implication in the presence of TP53 mutation. When we try to have early hematopoietic stem cell transplant, it's important to know the load and the mutational burden of the patient because of the prognostic value. As I mentioned, they can help to identify inherited predisposition, and the importance of the recognition of clonal hematopoiesis and the diagnosis of uncertain cases is extremely valuable. We are trying to evaluate whether this somatic mutation evaluation is useful to predict response to some therapy like hypomethylating agents, but surely it's indicative of the possibility to use target agents. This is the WHO classification, and as you see, it looks quite simple, but as actually a novel approach has been to identify as MDS with ring sideroblasts the cases in which ring sideroblasts were higher than 5% but lower than 15%, but that harbor SF3B1 mutation. So for the first time, we have a molecular data that comes into the WHO classification of MDS. We know that spliceosome mutation are very frequent in MDS. They are present in more than 60% of the cases of MDS, and these in red are the most frequent ones encountered in MDS. We know that in MDS, especially for low-risk MDS, some mutation have a real prognostic importance. And as you see here, we have a TP53 mutation, EZH2, ATV6, RANKS1, and SXL1. These are the most important mutation for prognosis and lower risk MDS. SF3B1 mutation, as I mentioned, is not only useful for the classification and of MDS, but has also very great importance in terms of prognostication. In fact, patients who have SF3B1 mutated do have a good prognosis and a longer overall survival compared to patients who have no mutations or patients who have one of the mutation I just shown or other ones like CBL or U2F1. So can we use somatic mutation to help us in diagnosing an MDS? Dysplasia can be induced by other causes than MDS, and sometimes cytopenias without dysplasia are just very difficult to diagnose. So we are tempted to use the presence of somatic mutation to diagnose MDS. We know that the mutations are present in a higher number in higher risk MDS, that the number of mutation correlates with overall survival, but we know a little bit less on and we will discuss later how is that important for diagnosis. As you see here, as I just mentioned, the number of mutation increases with the worsening of IPSS and therefore of prognostic risk, so that the patient who have a higher risk MDS have the higher number of mutation. And as you see, patients who have more than 6 driver mutation do have a very poor overall survival. So these are for sure information very important from a prognostic point of view. We also know that patients who have more than 2 mutation or higher number of mutation have a poor overall survival even if they receive ESAs and they are lower risk. And again, the number of mutation still stands for a poor overall survival when you treat patients with lenalidomide. This is a study for non-del(5q) MDS patients receiving lenalidomide. And because of these data, there have been several attempts to implement the mutational studies into the IPSSR, so the international prognostic system. And this is a very interesting paper on, I would say, a limited number of patients, but with nice results, because this author included 3 mutations or more of the mutation of TP53 in the IPSS scoring system and called it molecular IPSSR. And as you may see, the stratification of patients, it's really optimal. This is another attempt to include in IPSSR a number of mutations. And as you may see here, the number of patients included is higher. And once again, the mutational studies do add in prognostic value. This is another important attempt, that is to evaluate patients only by the type and number of mutations you see, and evaluating only 14 genes. The authors have been able to stratify patients in an excellent way prognostically regarding overall survival. The model one is the classical one with the molecular data plus age, sex, and hematological data, and as well as IPSS. The variable in IPSSR. And as you may see, by themselves, the mutation are able to stratify patients in an optimal manner. This is why the International Working Group in MDS has set a huge study, including more than 4,000 cases of MDS collected all over the world. And the final number of patients included in the study and presented by Elsa Bernard last year, it's more than 3,000. Of all these patients, we had clinical annotation, therapy annotation, so that we could really evaluate the prognostic weight of mutation in MDS. And this is what was done in 25 centers, 13 countries in Europe. Now, the data are quite mature and will be presented at Next ASH in a couple of weeks. Now, there have been several studies over the years. This is one of 2011 of Raphael Bejar and other studies that have tried to identify the exact prognostic impact of mutation, but still what we need is the results of the big data of a huge number of cases to really evaluate the importance of these studies. This is a small study carried out by Alice Brogi in my lab, and you see that even when you consider a small number of cases, the majority of them do have at least one mutation, and some of them have more than 3 mutations. But the importance for overall survival is kept even when you consider small number of patients and few mutations. Some of these mutations, again, were confirmed to have a bad prognostic impact, like RANS1 and DMLT3A. But the worst mutation that we know, and we know that is conferring a real poor survival, is indeed the mutation of TP53. Now, this is a paper that has been published last year, in which the importance of the TP53 mutation was clear even in the cases in which MDS had a complex karyotype. If you see here in black, you had a patient with complex karyotype with less than 5 chromosomal abnormalities, but no TP53 mutation. So a very poor prognosis by itself. but worsened significantly by the presence of TP53 mutation, even without more than 5 abnormalities. So you have complex karyotype, super complex karyotype, I would say, and then you have TP53 mutation that are really the patients with the worst survival. And you see here in detail, if you have a monosomal karyotype and TP53 mutation, and if you have a non-monosomal complex karyotype, this mutation is always really prognostically negative. But this is not so easy and not so simple, because the allelic state of TP53 may change the clinical outcome. So what we consider a unique mutation is in fact different, because when we analyzed a large number of cases in the IWG group, it was clear, and it has been published in Nature Medicine this year by Elsa Bernard. You see that the TP53 mutation can be different. They can be monoallelic, and in this case, they do not change so much overall survival, but the multi-allelic and multi-hit TP53 mutation do have indeed the worst prognosis. And this is true also in the 100 or more patients with del(5q included in the study who received lenalidomide. You see, these patients are known to be responsive to lenalidomide and have prolonged overall survival by this therapy. But in the presence of multi-hit TP53 mutation, this advantage in overall survival is no longer present. In the past, it was known that by itself, TP53 mutation was a negative prognostic factor for del(5q MDS. This is not exactly going to be the case, but what is very important is that in any diagnosis of MDS del(5q, we have to evaluate the presence of TP53 mutation and their allelic status to know exactly what is the prognosis and whether lenalidomide therapy is possible and allowed. In del(5q, there are several mutations, and they're a little bit different in frequency from the ones we see in non-del(5q MDS. One is peculiar, that is casein kinase 1 mutation, but the prognostic impact is different. In del(5q, SF3B1 mutation has no prognostic good impact, differently from the non-del(5q. So that you see here that del(5q patients have a good overall survival, but not when they carry the mutation of SF3B1. Whereas in black, the non-del(5q plus SF3B1 mutation are having a quite good prognosis. What is the importance of mutation in the patients who undergo hematopoietic stem cell transplant? There have been several studies showing that the presence of TP53 mutation is indeed correlating with the worst overall survival. And it has been shown also that RANKS1, SXL1 mutation do confer poor prognosis after transplant, and this should be evaluated every time we decide and we plan a transplant for a patient. You see that several studies have shown this. The relevance of TP53 mutation in the transplant procedures, it's independent from age. So patients who are older than 40 or younger than 40 with the TP53 mutation do have apparently the same poor outcome. So it's a very strong variable to evaluate. Another important contribution of the molecular studies in MDS is the fact that we can identify inherited predisposition. And the WHO classification of myeloid neoplasm included germline predisposition and included the myeloid neoplasm that can be recognized by these specific molecular abnormalities. So when should we study, in this sense, an MDS patient? We should evaluate the patients who are younger than the median age of MDS, around 50 years or below 50 years. But we should not exclude the suspect of inherited predisposition for older patients. Patients with multiple cancer or with a familial history of hematological malignancy should be evaluated. And we should also search for hidden signs and symptoms of congenital syndromes. We should perform mutational analysis for genes involved in inherited predisposition, or even better, the whole exome sequencing. This is particularly important if the patient is planned for a stem cell transplant, because the donor should, the familiar donor should be very well evaluated. And of course, all these studies do prelude to a familiar genetic counseling that is extremely important. This is what we did in Florence. We evaluated the younger patients who came for with a diagnosis of MDS, and we evaluated the whole exome sequencing on bone marrow cells as well as on saliva or fibroblasts to detect germline alterations. 20% of younger MDS patients tested carried, in fact, germline and predisposing mutation. So it is really extremely important to evaluate this. And again, the question I had before, can we use somatic mutation in the suspect of MDS? Can we really go to diagnosis in an easier way? Well, it's not so easy, because there are some difficulties because of the presence of clonal hematopoiesis. You see here all the definitions, CHIP and ARCH, so age-related clonal hematopoiesis, is a clonal hematopoiesis that can be present in 15% of patients older than 70, but more recent studies suggest that this percentage is even higher. The mutations that are typical of clonal hematopoiesis related to age are the same that we see more frequently in MDS. And this is the fact that is rendering the use of molecular mutation more difficult to help in diagnosis. The NMT3A, SXL1, and TET2 are the mutations that are mostly present in clonal hematopoiesis. We know that clonal hematopoiesis correlate with inflammation and with coronary heart disease. And this has been shown also in murine models. And what is most important is that we may, in fact, evaluate the presence of mutation and try to interpret them in terms of diagnosis. So I just presented you with the clonal hematopoiesis called CHIP and ARCH, mostly almost equivalent. The median number of mutation in these two situations is 1, and the variant allele frequency is not above 10 in ARCH and around maximal 12 in CHIP. And as you may see, you have this the so-called DAT mutation, sometimes more rarely JAK2 and TP53. But then you may have cytopenia and clonal hematopoiesis. This is really difficult to diagnose differently from MDS. And what is the threshold from Sisyphus and MDS? You see that the mutation here may be even 2. And what is more important is that the allele burden is higher, 30-40%. More different mutations appear in this stage. And then you can pass to really the diagnosis of real MDS, lower and higher risk MDS. The number of mutation is usually more than 2, and the variant allele frequency higher than 50%. Many other mutations do appear. So when we try to confirm a doubtful diagnosis of MDS with somatic mutation, we have to take into account the age of the patient. So if a patient is younger with isolated cytopenia, I don't know whether it's an ICUS or an MDS or a Sisyphus, I have to the possibility to evaluate mutation. But if the patient is elderly, I have to be very careful because it may be only clonal hematopoiesis, and therefore I can confirm MDS only if the variant allele frequency is very high. On the other hand, the presence of CHIP may predict a progression to MDS and AML by, again, the number of mutation and the variant allele frequency, so that you may predict even some years in advance whether this patient will have a progression to AML or MDS, if they have more than one mutation, what is the mutation-specific risk. Some mutations are more at risk, like IDH1 or TP53, and the variant allele frequency. So it's a powerful tool that we should really learn how to use to predict the progression in healthy individuals. Finally, I want just to say a few words on somatic mutation and response to therapy. You know that there are many markers, proposed markers of response to several agents, and especially to hypomethylating agents. There has been a lot of discussion in the past years on the better response conferred by the presence of TET2 mutation, apparently only when TET2 has a variant allele frequency above 10%. But these data have not been confirmed in all the studies carried out afterwards. This is a very interesting study that employs artificial intelligence and machine learning methods. So the association rules for a combination of biomarkers, in this case of mutation, allowed the identification of patients, 30% of cases, who were not responsive to HMA. So with a very good power of 87 and 93% in the confirmatory study. So this is a possible use of the combination. No single mutation was able to predict for azacitidine response, but the association rule allowed to identify 30% of cases were not responsive to MDS. In our lab, we could not, in fact, detect or confirm any single mutation that could confer higher or lower response to azacitidine, as well as what we had for CMML treated with decitabine. We could not identify a mutational pattern predictive of response to decitabine, but for some other cases, we do know that identifying a mutation can predict response to therapy, like it happened for SF3B1 mutated MDS and treatment with luspatercept, or in non-del(5q) patients treated with lenalidomide, for which ASXL1 was a negative predictor of response, whereas DNMT3A and EZH2 had a trend to a better response. DNMT3A mutated patient treated with lenalidomide had a significantly better overall survival than the patient not receiving lenalidomide. Other mutations like IDH1 and IDH2 are very rare in MDS, but they do have specific inhibitors, and therefore could be used in the treatment of MDS. They have been approved for AML carrying this mutation, but I hope that the data published by Ettenstein in Lancet Hematology a few months ago will prompt the approval of these drugs for target therapy in MDS, because as you see, 50% of them got response. And this is why we are carrying on with studies based on the presence of, in this case, IDH1 mutation. These are data that will be updated at ASH 2020, showing the activity of the APR246 together with hypomethylating agents in patients carrying TP53 mutations. These are patients that, as I mentioned before, are resistant to therapy, but they get 85% of response, overall response, when you add this new agent. Now, I give you an overall idea of what we may do and we may obtain by studying molecular MDS. We have to put some order in these studies. The Spanish group for the study of MDS published this interesting evaluation in which they give some guidelines for the use of NGS and target sequencing in MDS and CMML. I wish to thank all of you, and I hope you have some questions for me. Now, I want to give you this this take-home message. The molecular analysis of MDS can really refine the diagnosis in some cases. Molecular analysis with NGS at diagnosis can improve the prognostic stratification, especially for some cases. In Del5Q MDS, the assessment of TP53 mutation is mandatory, and the presence of actionable somatic mutation may help to select target therapy, especially in second-line treatment. And I really thank you for your attention.
Thank you very much, Professor Santini, for this great presentation. I think there is already the first question. Could you please tell me, Professor Santini, if you can see it in the chat?
Okay. How do you test for multi-hit TP53 in your center? Now, this is a very interesting question. Of course, we do not, you have to know whether you have a high variant allele frequency, if you have a loss of heterozygosity. So you should really go a little bit more in depth with a normal NGS. This implies that we do have to change our approach to evaluating TP53 mutation. It has been suggested in the past in a very, let's say, in a very routinary and standard way, but now we have to really have the tools to do to elaborate it a little bit more, because you have to evaluate the allele frequency, once again, the presence of loss of heterozygosity, a lot of testing more. Now, there is another question. Do you suggest to evaluate low-risk MDS patients and life-threatening cytopenia with specific somatic mutation for hematopoietic stem cell transplant? Well, it's a temptation we have, in fact. What I would like to say is that we are not still completely ready to do so. And I can tell you what I do. If I have a patient in which I am doubting whether to let the patient undergo transplant, I, of course, consider also the type of mutation and the number of mutation. So if the patient has a transfusion-dependent anemia and has 5 or 6 mutations, then I fear that this low-risk patient may evolve to a higher risk. Whereas if I do have a patient that has a couple of mutations and not specifically poor prognostic ones, I'm more cautious. But I'm really eager to see and to be able to show the results of the international working group to be able to really evaluate the prognostic impact of in lower risk MDS. It's a very interesting question. We are still not completely sure that we can trust it. I have another question. Is genetic predisposition identified only in younger patients with MDS? No, as a matter of fact, no. We should consider all patients, because sometimes patients who are older or in the median age of MDS may, in fact, have a genetic predisposition that is not apparent in morphology with the sign that may allow you to suspect it. So for sure, I will investigate it in younger ones, but I will not exclude it in older ones. And this is another question. Any evidence of better response to ESA in specific molecular subset? We have been evaluating it. We had data showing that in univariate, patients who had more than 2 mutation in lower risk MDS treated with ESA would respond less, but in multivariate it was not as strong as in a strong prognostic variable. Not as my knowledge, there are unique mutations that predict for response to ESAs. And SF3B1 and Del5Q are patients who do respond, but for a shorter time, but not really an indication of specific response. Would you give TPO agent agonist to a mutated patient with thrombocytopenia? I rephrase the question. Would be a MDS patient with thrombocytopenia and a mutation. I would give, it's off-label anyway. You can't give it. So if you talk about MDS, it would be within an investigational trial. And if it is an ITP with mutation, then I would be in a sort of Sisyphus setting. Well, once again, it's not completely, approved. And I would be careful because we don't know. I mean, both romiplosting and Trombopac do work in MDS, but they have not been approved for several reasons. And therefore, I would be very cautious in these cases. How do you make the difference between TET2 or DNMT3A? We carry an NGS evaluation, so we study and investigate a number of mutations, the most frequently recurrent in MDS and in myeloid malignancies, and TET2 and DNMT3A are always included. I'm not sure I understood the question correctly. The panel include all the panels, the let's say the smaller one as well as the most extended one include always TET2 and DNMT3A that are the most frequent, two of the most frequent mutation in MDS. There is another question, age-related or leukemic clone? As a matter of fact, I showed the graph. If you want, I can show it again, in which this is what we try to do now to evaluate whether a patient has a chip or okay. Now I understand. Between TET2 or DNMT3A, age-related or leukemic clone. Sorry, it was the last part of the question was lacking. As you see here, now you have DNMT3A and TET2 who are in the ARCH and CHIP, the age-related clonal hematopoiesis, have a low variant allele frequency. When we do have a driver mutation for a leukemia or an MDS, you see that the variant allele frequency is pretty high, from 40 to more than 50%. So that's the way you normally distinguish the age-related from the really MDS-related. So in age-related, the variant allele frequency, the VAF, is pretty small. It's around 10%.
So thank you very much, Professor Santini, for leading this great comprehensive session. And also, I would like to thank you very much, audience, for such a great discussion. And before we go, I would like to invite you to fill in the survey we will send to you after this webinar. We would appreciate the feedback because we can fine-tune this session according to your expectations. And of course, please register to the upcoming webinars. The next one will take place 3rd of December. And of course, please subscribe to our newsletter. Follow us on Twitter, LinkedIn, and Facebook, and visit us at the EuroBloodNet Edu YouTube channel, where we publish all the webinar sessions. Thank you very much, Professor Santini, and thank you, audience, and see you next time.